webinar. Okay, we see the attendees coming in. Okay, well, welcome everyone. We'll be just starting in just a moment. Okay. All right, well, welcome everyone. We're just going to give another minute or two and we'll get started. Thank you. Great. All righty. So let's go ahead and get started. All right. So welcome to the Lunch and Learn, and thank you for joining us today. First, let me introduce myself. My name is Keiko Miyahara from the University of California, San Francisco. I'll be hosting today's presentation, and I'm delighted to welcome the three speakers who will present on dental care coordination through systems approach to increase access to dental care for Medi-Cal recipients, Alameda County's experience. So let's go ahead and go over some housekeeping tips. So some logistics before we start the presentation. Everyone is muted, so if you experience any technical difficulties during the webinar, please use the chat box to connect for help. We will be running a live Q&A, so please use the Q&A box to ask questions during the webinar. We would like our time together to be engaging and exchange dialogues. Lastly, this presentation will be recorded. A video file and relevant links will be available on COTAC's website. Okay, so I would like to welcome our speakers. Our first speaker is Dr. Kwamran Elridge. She's the Director of Community Health Service Division of Alameda County Public Health Department. She has over 25 years of experience working in public health in the United States and internationally. She joined Alameda County Public Health Department in 2000. Currently, she oversees 8 different programs, which includes dental health program. Our second speaker is Dr. Bhavna Ravi. She's the Community of Practice Manager for the Healthy Teeth, Healthy Communities Project in Alameda County's Office of Dental Health. She plans and organizes the CE courses for the network of dentists participating in this project. She's a general dentist with 10 years of experience in community and private practice in the United States and Australia. And our third speaker is Dr. Suhalia Khan. She was the project director for Healthy Teeth, Healthy Communities Project in Alameda County's Office of Dental Health. She joined the project in 2017 and currently oversees data evaluation sustainability activities. Dr. Khan is a public health physician and health economist by training. Her expertise topics are dental, care coordination, diabetes, cancer, reproductive health, vaccination, workforce pipeline, and nonprofit and government sectors. With that, I would like to turn this presentation over to Dr. Elridge.
Thank you, Keiko. Thank you for inviting Alameda County to share our dental care coordination experience with the LOHP team. Many of you know that Alameda County Office of Dental Health is in existence for over 40 years, and we have been doing dental care coordination for many years. Years ago, when we had our visionary dental health administrator, Dr. Jared Fine, he introduced dental care coordination along with other programs. It was a small program and was implemented only by our staff. At some point, county did not allow us to do dental care coordination or care coordination using community health outreach workers. So we created a care coordinator classification to continue the care coordination services. In 2016, when the opportunity came through 1115 waiver, we took the opportunity to create a dental care coordination project that we always dreamt about. This countywide initiative that we proposed for DTI grant was innovative, but it was also complex. County did not administer this kind of complex project before. The grant started in April 2017. We spent 2017 for planning. From January 2018, the care coordinators started working in the field. As a new program, for the first 6 months, we faced a lot of challenges. We worked without a database. In early 2018, we lost our dental health administrator. The project was new, all staff were new. At that time, I felt that I have to pay extra attention to this project. I assured the staff and the partners that I'll make this project a priority. In fact, the Public Health Department's leadership, Healthcare Service Agency leadership, Board of Supervisors, everybody provided support to this project. It was not only our credibility issue, I also felt that our partners trusted us to lead this project and make it successful. So in absence of the dental health administrator, I kind of became the default dental health administrator. Although the project period was 3.5 years, we only got opportunity to do full care coordination for 2 years. Due to the pandemic, 2020 productivity became very low. Later, when we show our data, you will see that. I said that the project was complex, but believe me, it was a fun project. I have been working with the Alameda County Public Health Department for the last 20 years. This is the best project I ever worked on. This project showed creativity, dedication, multidimensional partnership, quality, and result. In the grant, we promised to do a lot within a short time. So we realized that we have to be highly functional in a fast-paced environment. So we utilized our staff time very efficiently. We created a team framework. Everything was a team effort. You will see that example here also. Today's presentation was created by a team, and all of our team members' names are included here. We also have with us our management staff, our project director, Arash Aslami, epidemiologist, Ilak Fantai, community dental champion, Dr. Jared Fine. They all are here as panelists in case you have questions for them. Normally, when we present, we say what we did. Then many times we were asked how we did it. For example, we were asked how we convinced the dentist to participate in our program. So today, we'll not only talk about what we did, we'll also talk about how we did, what was the result, and what is next. Let's start with the PowerPoint and hear from our next team member, Dr. Bhavna Ravi. Dr. Ravi.
Hello, thank you. Thank you, everyone. Thank you, Dr. Eldridge. Good afternoon. I would like to start off by thanking Dr. Kumar and the COTAC team for inviting Alameda County to present our work on oral health. And many thanks to Kiko and Nancy for their assistance with logistics. So let me start with the learning objectives for today. It is to discuss and explain the effectiveness of dental care coordination model through a systems approach to increase access to dental care for Medi-Cal beneficiaries in Alameda County, mainly about what we did, and to discuss and describe the strengths and challenges of implementing Objective 1 in a large county-wide collaboration, which is how we did it, and to discuss the results-based program and policy implementations as to what are the next steps. So talking about a context, the context for our oral health work was the need to increase access to dental care. And this need exists throughout the state of California, as well as in Alameda County. Alameda County is located by the San Francisco Bay Area with a population of close to 1.7 million. We are the 7th largest county population-wise. And we have a very diverse population, diverse by race, ethnicity, age, and gender. So where it all started, just a quick background. Back in 2015, 2016, there were 2 state reports that highlighted the need to increase access to dental care and improve California's Medi-Cal dental program. One report was the 2015 state audit report, which found that fewer than 50% of the under 21-year-old beneficiaries had accessed the Medi-Cal dental program. After the audit report, the state legislature convened the Little Hoover Commission. The commission took written and oral testimony to better understand the reasons for the failing Medi-Cal dental program. They wrote a report in 2016 and listed the barriers to access care. The Little Hoover Commission report listed the barriers in 3 major categories, which were the dental provider factors, the client factors, and the system factors. The 3 categories of barriers can be diagrammatically represented through this Venn diagram. This diagram reflects how a necessary system of care could facilitate or mediate a connection between providers and clients. So how it all began. As a result of the reports, the California then successfully sought a 1115 Medicaid waiver to authorize a $745 million grant towards a dental transformation initiative to fix the program. Alameda County is one of the counties to receive the grant to conduct a local dental pilot program. Alameda County's local dental pilot program is called the Healthy Teeth, Healthy Communities project. The project period is from April 2017 to December 2020, and the total funding was $19.7 million. With that, I'd like to turn this presentation over to Dr. Khan.
Thank you so much, Dr. Ravi. So I'll start with what we did. Basically, we built an effective dental care coordination model through systems approach that led to increased access to and utilization of dental care for Medi-Cal children and youth ages 0 to 20 years in Alameda County. The HTHC goal was to increase access to preventive dental care services for Medi-Cal children and youth ages 0 to 20 years in Alameda County. The objective was to create and implement a new model of countywide dental care coordination system in Alameda County. To achieve the goal and objectives, we had 3 big action items. The number 1 action was to create community dental care coordination CDCC workforce. The second one was to create a network of dentists called Community of Practice. And action number 3 was to collect, analyze, report, and use data. And towards that, we created an online database. And to support these actions, we had 3 big sub-action items. The sub-action number 1 was continuous quality assurance. Sub-action number 2 is leadership administration, and communications. And sub-action number 3 is building and utilizing partnerships and collaborations, both public-private and across medical, dental, and behavioral. I think my slide is not moving. Okay, it moved. So this is a graphical depiction of our countywide dental care coordination system. At the core is the CDCC, or Care Coordination Workforce, that works with the COP, or provider network of dentists. And the CDCC workforce is the one that is the bridge between the patients and the providers. And this core has to be supported by data collection, analysis, and use, continuous quality assurance, and leadership, administration, communication, and partnership. Action number 1 is creating community dental care coordination workforce. This is the bridge connecting the patients and providers. So the 14 agencies who are our partners, we hire 26 CDCCs from 8 FQHCs, 2 community health centers, 2 community-based organizations, and 2 county programs, ODH and CHSC. All these 26 CDCCs are culturally and linguistically sensitive. The responsibilities of the CDCC workforce are multifaceted. They are supposed to do outreach and inreach to find families with children who are on medical or medical eligible. They educate families about oral health, and they educate families about using medical dental services. We found that a lot of families knew about the medical services, but not the dental services. The CDCCs assist families with dental appointments, scheduling, showing up, accompanying clients to the first appointments, conducting the follow-up calls. The CDCCs also established and maintained a good working relationship with dental providers. They also collected and entered data in the online database. They also attended the project trainings and meetings that were scheduled. Action number 2 addresses provider factors. We created a network of dentists called the Community of Practice. 164 dentists were recruited. 133 came from 8 FQHCs, 29 from 23 private practices, 2 from 1 community health center. We also deployed a champion, and we gave him a very fancy title, Community Dental Ambassador. It was Dr. Jared Fine. So the COP provider responsibilities were accepting medical patients, especially by private dental offices. And they coordinated with CDCCs for patients' dental appointments. The second point that is highlighted in green, it was crucial in increasing the access to and utilization of care by the Alameda County children. The COP provider offices also completed documents like the dental encounter form and submitted those to us. They participated in trainings and mentorship program. We provided 14 continuing education courses in these 3.5 years, 49 units at no cost, and the trainers were the UCSF faculty. We also had 17 pediatric dentistry mentors in our program to support these dentists. You have to remember that most of the dentists in our programs are general dentists, but they were looking after children 0 to 20 years old. These COP providers also provided family oral health education, or FOHI in short, to families with children 0 to 5 years old. Action number 3 was collecting, analyzing, reporting, and using data. So first, we created a database that emphasizes dental care coordination. It was cloud-based, online, live, fully HIPAA compliant. The 26 CDCTs were able to collect and enter data in real time in this database, and that enabled us to do real-time monitoring and reporting of our progress of our program. We created CDCC monthly report with targets. We conducted surveys, we did client satisfaction surveys in English, Spanish, and Cantonese in 2019 and 2020. We did CDCC satisfaction surveys. We did CDCC knowledge, skills, confidence surveys, twice, once in 2018, once in 2019. We did COP satisfaction survey after every CE. So that was done 4 times annually. And we started in 2017 and we finished in 2020. We also did COP follow-up baseline surveys 3 times, once in 2018, once in 2019, and once in 2020. We also did focus groups. In 2018, we did 12, 6 client, 2 CDCC, and 4 dental providers. And in 2020, because of the pandemic, we did dental provider focus groups via Zoom. And every information we got, the data we got, whether it was from the database or whether it was from the monthly reports or whether it was the surveys or focus group, every information was used to make program improvement while the program was still being implemented. Sub-action number 1 is very important, continuous quality assurance. Even if we have data, it doesn't mean that, is going to, impact the quality of the program. So our project, we formed a group called Accountability and Quality Improvement Work Group, AQI. We met monthly, and our partners were ODH, UCSF, and Alameda Health Consortium. This is the group that developed the data collection tools. This is the group that conducted all the surveys. This is the group that analyzed the data, and we were able to use the data. We did additional data quality checks. We did monthly error reports from the databases. Ilak Fante, who's a panelist, he would generate these spreadsheets. We would send them to the 26 CDCCs. They would correct them and send them back to us. And then, our staff would double check that that the CDCCs actually corrected the data. We did a very extensive data audit in 2019. All 26 CDCCs, about 7,500 clients when we did this audit, every client data was checked. Did they have the signed consent form? Did the names on the consent form match the information we have in our database? A few examples of, the using the data for quality improvement. For example, from the CDCC surveys, we found out that the CDCCs were interested in learning more about HIPAA and, the medical dental program. So we organized refresher trainings for them based on this information. From the COP surveys, we found out that the general dentist wanted to practice more case scenarios on how to treat children ages 0 to 5 years old. And we gave that information, to our UCSF faculty, and they, incorporated that in all their CEs. The CDCC monthly targets. If the monthly targets were not met, I would pick up the phone and call a project director and ask, what's going on? Can we help? What do you need? So information was collected and information was used to make program improvement and adjustments. So this shows, the structure of where the Office of Dental Health is located. It's part of our Public Health Department, which has, community health services, of which Dr. Kamrun Elridge is the division director. And, of the 10 programs, Office of the Dental Program is one of the programs. And you can see that, Healthy Teeth, HTHC is there. We also have Healthy Smiles, Big Dental Day, School-Based Program, and the other LOHP programs. So Alameda County already had a dental public health program in place, as mentioned by Dr. Elridge earlier. And Dr. Jared Fine built that over the last 40 years while he was the dental health administrator. And then the next dental health administrator came on board, Dr. Barak Amanzadeh, and Dr. Amanzadeh and Dr. Fine wrote this brilliant HTHC grant, discussing how we were going to build this county-wide care coordination system. And then I came along and I implemented their vision. And Dr. Elridge also mentioned that Office of Dental Health hasn't had a dental health administrator for 3 years, but she provided us that high-level support so we could move this project. The point of this discussion is that Alameda County didn't go from zero to a $19.7 million project. We had a lot of things in place already. Dental public health was already big in Alameda County. We were already doing population rather than individual, prevention rather than treatment. And all the partners who participated in HDHC, those who had leadership at all levels, also performed very, very highly in this project. So leadership is very important for having a vision and infrastructure and implementation. Sub-action number 2 also includes, having a very disciplined administration and having multi-level communications. So this is our calendar of mostly external meetings with our partners for 2019. We planned out our meetings 12 months in advance. We booked rooms. And you can see, for example, the implementation meeting, it met weekly, Thursdays, 9:30 to 11 a.m. This was on everybody's calendars. We met with the 26 CDCCs and supervisors, about 40 people, monthly. It was usually the last Thursday, 8:30 to 4:30, all day long. This is the quality assurance AQI group. We are still meeting monthly. We started in 2017. And, we are going to keep meeting till December, second Tuesdays, 1 to 3 p.m. And we use these meetings to communicate with our partners on a regular basis. And we also use this to actually communicate, with our own staff. There was a lot of things going on. And we anticipated that this is a pilot project. There will be a lot of challenges, but we also needed to address these challenges to be successful. So every meeting we used to help form a learning network, and also we used it to problem solve. Every meeting ended with a solution. We didn't leave meetings without solutions. And that was really instrumental in making this project a success. There are 2 meetings that are not on here. One of them is the morning huddle I started in 2018 with just our staff. We had 12 staff. And it was a way for us to build team spirit and also problem solve as a team spirit. Another important meeting was the monthly meeting of the dental directors that was organized by Alameda Health Consortium, one of our partners. They gave us half an hour every month to come and talk about HDHC. And it was a very useful forum to, again, communicate with the dental directors and what the provider issues may be. Sub-action number 3 is about building and utilizing partnerships and collaboration. We mentioned that this is a county-wide partnership and collaboration. It was between public and private, between dental, medical, behavioral, between county and UCSF, between county and Alameda Health Consortium. We have 40 partners. 17 are agencies and 23 are private dental offices, including those 8 FQHCs, 2 community health centers, and 2 CBOs. The county had existing relationships with most of these partners, but never with all of them in one project at the same time. So this was first for HDHC. This is a snapshot of our valued partners. It doesn't include the 23 private dental offices who are also our partners. Their names are not included here because they've requested us not to show their names in any public forum without their permission. And we've maintained that request throughout the 3.5 years of this project. So that was what we did. Now, how we did it? And it sounds like we did one thing, one step at a time, but everything happened, simultaneously. There was no one thing at a time. And so how we did it, year 0, it was a lot of pre-grant activities. And then year 1, 2017, was a lot of planning activities. And field work was done in year 2, 3, and 4, 2018, 2019, and 2020. But mostly we weren't able to do much for 2020 because of the pandemic. And you'll see in the data where we started falling off. So here's some examples of the pre-grant activities we did. The Alameda County Office of Dental Health provided the leadership to write the grant. The partnership with the 17 organizations was built before the grant was written, and the grant was written in collaboration with the 17 partners. The job responsibilities of the CDCCs were developed with the partners. The FQHC dentist participation was formulated with the FQHC dental directors before the grant was even written. Year one, project started April 2017. We were planning and developing the project implementation tools. The CDCC Workforce Curriculum Advisory Group was formed. They were meeting weekly. Care Coordination Advisory Group was formed. They were meeting monthly. The COP Leadership Group was formed with UCSF. They were meeting twice monthly. The COP and CDCC curriculum development started. The Quality Assurance AQI group was formed with UCSF and Alameda Health Consortium. The database design discussions started with the vendor. Implementation plan, the meetings started in 2017 and we started writing the plan and we finished writing early 2018. We also started, thinking about an evaluation plan for this project and, started writing it and we finished it around mid 2018. So this is our implementation plan from 2018. This one is the implementation from 2019. Now we've converted our implementation plan into a wrap-up plan and we started doing that in August. And this is, what our evaluation plan cover looks like. So the CDCC workforce activities, they started in October, November. They were going on in October, November, and December of 2017. We finished developing the 8-week curriculum training for them. The topics included oral health, care coordination, outreach principles, dental terminology, data entry. We also recruited, mostly by the partners, hiring the 26 diverse CDCCs. We trained the CDCCs. The trainings were organized by ODH. We provided them with iPads for entering data. We gave the CDCCs targets and benchmarks based on what we said we would do in the grant. So each CDCC annually is supposed to contact 600 families with children or youth, schedule 276 dental appointments, get 179 children and youth to a dental appointment, and provide continuity of care to 116 children, youth per year. And then we broke it down to per month so they can, fulfill their targets better. We developed lots of tools for our CDCCs. For example, this is a goal-setting tool that the CDCCs used when they were giving oral health education to the families. And then, this one is about, the urgency of the decision, dental care decision tree, what is urgent or, not urgent. And then we also created a monthly progress report, for the CDCCs.
So Dr. Khan, if I may interrupt, there's a question from the audience.
Sure.
And this is an anonymous question, and it's asking, what is your plan for continuing these activities in future years?
That's a very good question and a very important one. And we will cover that, towards the end of this project. So if you can be patient and hold on, we will definitely discuss those. Thank you.
Thank you.
So we developed these types of tools and gave them to the CDCCs. This is a consent form. This was later translated in 7 languages. This is a dental encounter form. This was also translated in 7 languages. And these languages are based on the data we got anecdotally from the CDCCs and also through our database of the languages that are spoken by our clients. So we gave all those tools and trainings to the CDCCs and said, okay, now go and do care coordination. And so they started doing that. On the left, you see pictures of the two CDCCs from ODH, Lilian and Nandita. And then on the right, you see, the pictures of the Tiburcio Vasquez CDCCs. They were doing outreach. They would go to health fairs, week sites, and they would take, they would do tabling. They would take dental hygiene supplies and try to give, health education to the families, and then also motivate them to participate in this program. And so when they started doing that, we started coming across, our first challenges. One of them was that the dental providers, both private, FQHC, dentists, and front office staff didn't know who the CDCCs were. So the solution was that, we started setting up introductory meetings of the CDCCs with these providers. The private dental providers, office staff were also uncomfortable working with all 26 CDCCs simultaneously. So our solution was, have a lead CDCC for each private dental office, and the other 25 would coordinate with the lead CDCC to, schedule appointments with the private dental offices. And it was the same for, the FQHC dental offices too. Some of the private dental providers were very anxious. One of them had a nightmare that she woke up and there was a busload of medical children waiting outside her practice door. And the solution to that was about, our dental champion, Dr. Fine, would go and meet them one-on-one. And then, we would discuss, the practices can select how many children they would see in their program, what age group they were comfortable seeing, what appointment slots, they were comfortable giving it to us. So we let them, make those decisions. And that helped these anxiousness, go away. So we provided the dentist, 14 CEs in these 3.5 years. And we invited the CDCCs to come to at least 2 of them so that they could get to know one another. We tabled everyone, and the CDCCs sat in the same table as, the dental providers that they were going to work with. And this was a way to, build the relationship and get them to know one another, because both are needed to increase access and utilization of care. Then we came across our second challenge, which actually I realized by end of December 2017, that the CDCCs would start doing field work, but our database was not ready. In fact, our database would not be ready for another 6 months. But we needed some information immediately because we needed to report to the state. Also, we needed to understand whether our program was actually working or not. So immediately I asked our evaluators, can we have a 1-page paper data collection form? And they created one. We gave this to the CDCCs and said, please use this to collect this information and give this to us. We were manually counting the dental encounter forms that were coming back from the private dental offices. Access database was created. We created an appointment calendar, an outreach calendar. And I mentioned earlier, we had also created a monthly report spreadsheet. So this is what an appointment calendar looks like. So at the top, there's the provider's name. I crossed it out because it's a private provider. Provider's name, the service location, whether it's FQHC or private, and then the languages they cover, the services they cover, what age group children they accept. And then these are the appointment slots they gave our program. And if one CDCC booked a client for that time, they would put their names so that the other CDCCs would know what appointment slots are available and which ones are not available. So this was a Google Sheet that we used. Another one was the HDHC Online Outreach InReach Calendar. The CDCC started getting invites to go and do community events. And what happened the first couple of weeks is they went to an event. There were 10 families, but 20 CDCCs. And so there was a lot of duplication going on. So we created this calendar on Google Doc. And we requested the CDCCs that whoever got the first invite, put that information here. It's really tiny, you can see, but this is ODH, this is Axis, this is CHSC, this is EBAC. So their CDCCs, put the information there. And if another CDCC, wanted to go to an events, they had to check this calendar. And if somebody had taken that spot, then they had to coordinate with them. This was done to avoid duplication of our work countywide. We created more tools for the CDCCs. One was these frequently asked questions booklet. And another one, this I felt was a really important one, was a dental provider office protocol for the CDCCs. It included information like this. For example, this is Native American Health Center. What's their schedule? What are the types of services they provided? What are the languages spoken at this health center? They have 2 locations, so address of those 2 locations. Who can a CDCC contact, for this dental provider office? Who is the lead CDCC? Who's the supervisor? What is the best time to contact the office? How to drop off the dental encounter forms? How to pick them up? What are some treatment restrictions? What are the late and cancellation policies? We have this kind of information for every single dental provider office that participated in HDHC. We have some nice publications. We have this booklet, Healthy Teeth at Every Age for families with children. We have this booklet partnering with the Office of Dental Health for providers, so that, to motivate them and, give them information about oral health and dental health. We also wrote a guide for trainers based on the community of practice curriculum. This is available for use by anyone. These are all available on the ODH website. Please take time to go and find them. And we also have these in hard copies, these two. So if anyone is interested, please let us know. We can give you many copies to share with your colleagues and any clients you have. We created a program flyer, and then this was translated in 7 languages. And we informed our CDCCs that they could print their own name and contact information and put it on there and use this flyer as best as they could. We created a brochure about our program. We wrote reports, activity reports. We did 4 presentations at the APH annual conference this year. One lead was Jamal Yusuf, a young colleague of ours. Another one was Louisa Wong and Carrie Chen. One was led by me, and another one was led by Kristen Hoft from UCSF. I believe Professor Kristen Hoft and Ben Chaffee are part of the Kotak family at UCSF. So did we succeed? We talked about what we did and how we did. Did we succeed? It's a resounding yes, we succeeded. And the data shows that we succeeded. So
You cannot.
Keiko, I'm getting muted. Okay, looks like
We can
I'm
hear
unmuted.
you, Dr. Khan.
Okay, can you hear me now?
Yes.
Okay. So HDHC contacted over 49,000 families. And of these, 11,000 children enrolled, almost 12,000 children enrolled in the program. Of those children, over 10,000 children were scheduled for a dental appointment. And of those children, over 8,000 actually saw a dentist for preventive services. We made almost 33,000 dental appointments for these 10,000 children. And of those, over 24,000 appointments were kept. Our no-show rate for all dental appointments is 27%, but our target was 35%. So we did much better than our target that was in our grant. We also did a no-show rate for our first dental appointments, which is even lower at 18%. So this pie chart shows the distribution of our children, and this green area shows that half of our children were 0 to 5 years old. This is one area of weakness of the medical dental program, that they are usually not able to reach this age group, but our program definitively were able to reach the 0 to 5 year olds in Alameda County. Oops. This pie shows the race ethnicity distribution of our children. And Alameda County Latino Hispanic population distribution is about 22%. But in our program, we have 54% of our clients who are Latino Hispanic. Asian Pacific Islander is 18% and African American is 13%. In Alameda County, about 12% of our residents are African American, and about 35% are Asian Pacific Islanders. So definitely there's a greater need in the Latino Hispanic population in Alameda County. This pie shows that 2/3 of the dental appointments were made at the FQHCs, and 1/3 were made at the private dental offices. This graph shows the trajectory of our appointments. We started in Q1, and the orange line are the appointments that were made by the non-health center CDCCs, and the blue line are the appointments that were made by the health center, the FQHC CDCCs, like from Asian Health Service or Native or La Clinica. And as you can see clearly, the FQHCs were meeting their targets. In fact, most of them were passing 100% of their targets. And we kept going up, and we were at a comfortable level up to 2019, and you can see that the program crashed because of the pandemic in 2020, and now we're beginning to pick up again. This graph shows the no-show rates for the first appointments. The blue line is for the health centers. So they are mostly the FQHCs. They consistently had a very low no-show rate. Our overall program average is 18%. And as you can see, they are 9%, 13%. And even when they're going up during this pandemic, it's still, a very good rate. And the orange line is, a higher no-show rate for those non-health center CDCCs, like ODH or First Five. We don't have a dental clinic. We were mostly going to the private dental offices. We said in the beginning of the program that this is a county-wide initiative, collaborative. So did our children come from all over the county? The data says yes. We had children from Oakland, Hayward, Fremont, San Leandro, Alameda, Berkeley, Emeryville, Albany. They were from all over the county. So I think now, I'm going to hand it over to Dr. Elridge.
And yes, Dr. Elridge, we have about 40 more minutes for the presentation.
Thank you. So what is next? Let's see if it works. Yeah, it does. Okay. What is next? So definitely we'll not have that $20 million again next year, but what we see is encouraging. What we see is that there is a commitment to continue the care coordination workforce. You have seen that in the 10,000 children in Alameda County receive dental care through the dental care coordination. And our dental care coordinators made over 32,000 appointments within 2.5 years. And 50% of those children were 0 to 5 years old. And one good thing is that care coordination for medical beneficiaries, that care coordination activities that, for medical beneficiaries can be matched by the, I think I didn't put my camera on. Yeah, sorry. So can be matched by existing federal programs. At least one program already realized that. So we received funding from CHDP for 2.5 FTEs, 2 full-time CDCCs and 1 part-time supervisor. It will start in January 2021. So out of 26 CDCCs, at least 10 CDCCs will continue, 3 from ODH, 1 from Center for Healthy Schools and Communities, and 6 from 5 FQSCs. As you have seen that FQSCs realized the importance of care coordination, and because their no-show rate was below 10%. A CDCC curriculum we developed, and it will be available before the end of the year, and anybody can use it. In fact, LOHP programs can use it. I'm having problem with, okay. Commitment to continue the collaboration. So through this project, we strengthen partnership with our partners. So we'll continue partnership with UCSF, Alameda Health Consortium, FQACs, private dentists, dental societies, with all of them. And FQACs will continue collaboration among their medical, dental, and behavioral programs. For COP, the provider network will continue free CE courses with our partner, UCSF. In 2021, we'll have 4 free CE courses, and this can be expanded in statewide. The learning network for the dentist will continue, and ODH will continue family oral health education incentive payments. So here's the question: can this be part of the medical payment system? And COP training guideline is available. You have seen that we created a curriculum, and it can be used by any organization, can be used by other LOHPs also. The patient who found dental home through the SDSC program, they will continue to see those dentists. And we will include the private dentist as Healthy Smile provider with an ODH. Other things, we recommend that in dental care coordination program, always must include the care coordinators and the providers. An online database is available, and it can be modified for state LHP needs. A database is a very essential component of any program. And when we collect data, we must collect, analyze, and use disaggregated data by age, race, ethnicity, language, zip code, etc. Through this, we were able to show that what language our clients speak. We were able to reach 0 to 5 years old. Those were very important part of the outcome. And our program also showed that general dentists can treat children 0 to 20. All our dentists were general dentists, so even 0 to 5 years old. And one of the most important part was also that dental champion. A dental champion for every county would be very useful to interact with the local provider community. Here is our team. Without this fabulous team, we could not have done what we have done. And sometimes I feel that we are very lucky that we had the funding, we had the wonderful staff, and we had very dedicated partners. Without that, we could not have done that. Lastly, I want to say two things that I hope we were able to show the effectiveness of care coordination for dental public health. And if anyone want to have further discussion about the program or the resources, we'll be happy to discuss. Next. Any questions for us?
Yes, well, thank you, Dr. Elridge, and thank you, Dr. Ravi and Dr. Khan. I think there were some questions on the Q&A, but I believe, Dr. Fine, were you answering some of these questions?
I remember one question.
I was.
Yes, because last question talked about the case coordinators recruitment, and Dr. Fine, thank you for answering that. Yes, so now we have a little bit over half an hour. We would like to open it up for questions and answers and have an engagement session. So please go ahead and type your questions in the Q&A box.
I think if we could repeat those questions, I think everybody might benefit. I saw the two questions. One of them was how we recruited the CDCCs. Dr. Fine, do you want to share your answer for the group?
Yes, I think it bears repeating for everyone. We did the extraordinary work of partnering with 14 external agencies who are community-based organizations, as well as several agencies within the public health department, because we believed that the most important and most powerful relationships with the very community we were attempting to serve would be derived from the employment by the very community agencies that were serving those populations. So we therefore had to enter into contracts with all of those community-based organizations. But therein lies a tremendous value of having it be a system-wide, community-driven, county-wide program, because the CDCCs themselves were a reflection of the very population that we were attempting to serve. And their level of commitment and understanding of the population that we were intending to reach was extraordinary, something that could never have been achieved if they were all employed by the county public health department.
And also, the CDCC job description was determined by all the partners with, the county. So that was predetermined. And, when everybody was hiring, they had that, formula to use of, what was the expectations of the CDCCs and exactly what activities they'll be doing. And so that was very, very helpful. And one thing I forgot to mention is we covered social determinants of health for the CDCCs, but even before they were hired, it was, understood by the partners that that is something that we will have to be addressing, because, these are medical families. They have, a lot of issues. And one of them is, they may not have a job or, food. They may not be able to have, transport to get to the appointment. So the CDCCs would have to deal with these things.
I think I see another question about how the CDCC targets were, determined. So I think I can answer that, because we were doing care coordination before. So we had some data, we were doing for many years. And so we had data and we analyzed and we saw that one CDCC, how many clients they can see, and what's the percentage of making appointment. Based on that, we created that target for the CDCCs.
There's a question from Dr. Kumar. Have you looked at the CalAIM proposal for 0 to 6-year-old children, scaling up of the DTI Domain 2 initiative to every county? And if this is similar to the FOHI payment?
I did not read detail of that.
Yeah, it's
No,
the first
Dr.
time
Kumar.
I'm hearing this. Dr. Fine, do you know anything about that?
Well, Dr. Kumar has mentioned it to me, and it was a while ago, but in terms of the mechanics of how it would work, no, we really haven't investigated it. But I think it's a hopeful sign that there may be an opportunity with CalAIM to be able to incorporate the notion of paying for the family oral health education.
Dr. Kumar, thank you for bringing that to our attention. We'll follow up on that.
Yes, that's right.
Can I ask you a question, Dr. Kumar, since you're on there? We have developed a lot of curriculums, etc. And I know there are other DTIs who may or may not have, similar care coordination, for example, Fresno, and then Sacramento. DHCS has not been forthcoming about sharing these lessons learned. Is there a way for us to share information with you and take it to the next level? We've spent 3.5 years forming these networks. We have so many best practices, etc. And we would love to share these with other counties and also, learn from them. And I was wondering if there are venues to
Yes, DHCS has contracted with Mathematica for conducting interviews and evaluation for all LDPPs. And I am sure this is what they're planning to do, take a look at all the LDPPs and understand the interventions and the innovations and look at the lessons learned. So I'm positive that's in their plan.
Thank you, Dr. Kumar.
Thank you. Dr. Elridge, would you mind showing the slide for the COP network?
There is another question. What is CDCC stand for? CDCC stand for Community Dental Care Coordinator.
So I have I'm going to ask because I've been unmuted. So I'm wondering if you have similar care coordination for other conditions, children's health problems and issues, whether it is lead or
we do, Dr. Kumar. Yes, we do. For Family Health Services Division in Public Health Department, in maternal child health, we use care coordinators there also.
Mm-hmm. So how do you obtain reimbursement for those kinds of services?
So Family Health Services in maternal child health is MCH. Through MCH is matched through Title 19.
Okay.
So you have matching funding, so that the same thing will happen with us also. We do have care coordinators that work for CHDP clients or MCH clients. So we do draw, that's why I mentioned that we receive funding for CHDP additional, from January for 2 care coordinators that will be matched with their, federal funding, in fact.
Thank you.
Yes, and that can be used, for statewide. If anybody wants to match, those federal dollars.
Right. Thank you. Thank you for this excellent presentation and all the resources and materials you have produced. Yeah, I'll be talking to the medical dental program, and I know they've contracted with Mathematica to conduct the evaluation, and as part of them, they're going to be gathering all these materials.
Yes, Dr. Kumar, we did talk to Mathematica. They did interview us, and we told them that all the materials, all the information, and we want to, in fact, mail to them. And we said we would like you guys to take a look of what we have developed.
Okay.
Dr. Kumar, I'd like to encourage you to see if you can expedite some of the feedback from Mathematica, as I believe their final report will not come out for 12 months. And I think we might lose some momentum if we don't capture some of the very obvious successful lessons learned from the LDPPs.
Okay. Thank you.
Great. And then I also wanted to read a comment. This is from Dr. Penderkar. So she's saying that she has a CC funded through MAA for the CHDP program in San Mateo County as well. Yes, and we're getting a lot of comments as well. Linda Postam, thank you for this informative information. She's in Tuolumne County. And let me go ahead and go back to the slide that Dr. Khan was referring to.
It's the next one, Kiko.
Okay.
Yeah, no, it's the next one. The one that says, it's number 56.
Okay, so this one?
The next one, please. So Dr. Kumar, I had another question for you.
Sure.
So that first bullet point on this slide, this year, the last one, the September CE we did, we invited non-members to participate. Some of them are participating in the LOHPs. And, it's taken, the curriculum is done. And, we've tested it and it's very successful. And the providers want us to keep this going. But we have funding for only 1 year, 2021. And it takes a lot of effort to bring these into fruition. And we want to share this. When I talk to dental directors of other counties, they want to participate. And so we were wondering how to, make that happen.
Definitely, yeah. Let's talk about this. We'll set up a call and talk about this.
That will be great.
Dr. Fine, I know you had some thoughts on these two. Would you like to elaborate?
Yes, I'm happy to. When a continuing education course is arranged, given the current circumstances, it doesn't take that much more effort to provide an online opportunity statewide, for example, just as we're seeing with so many things like national conferences and so forth. So the effort will have already been accomplished for the continuation of the CE program, and I think it would just be a little push more to make it available on an ongoing basis. I know that our dear colleagues at the dental school are interested in making this kind of effort available beyond just Alameda County, and I think some partnership might be worth investigating beyond the next 6 months to make that happen.
Can you expand on what the CE courses look like? What do they cover?
Yeah, well, the courses are typically about the relationship of the dentist, who is typically a general practitioner, to treating, in particular, young children. So it deals with everything from motivational interviewing, behavioral management, the latest preventive interventions, evaluating cases, looking at treatment plans, a number of the things that are specific to treating and feeling comfortable with and competent about seeing the young child. And I have to say that at the local level, because in a county, one can establish relationships amongst the practitioners in a network. They also develop a sense of camaraderie and can not only get information from the continuing education course, but also feel supported in sharing information with one another and being supported. Part of that is the fact that we had 17 pediatric dentists say, yes, I will be a mentor. I will be available, and I am willing to be assigned one of the members of the community of practice if a question comes up, if a referral is needed, case consultation, and that broadened and deepened the support for the community of practice altogether, beyond simply the didactic information. Now, we also had the amazing luxury of going and taking advantage of a hands-on course at UC San Francisco, which was facilitated by the faculty at the pediatric dentistry department. But that of course is beyond the practical reality, given the fact that we might go beyond the Bay Area in making this available.
So who are these 17 pediatric dentists, and do they participate in Medicaid? Where are they?
Yes, some of them do, some of them don't. Some of them do it on a very limited basis, and some of them don't. But they were pediatric dentists practicing in Alameda County. Dr. Stewart, as you know, the chair of pediatric dentistry, and I co-authored an invitation to the specialists to become part of a mentorship collaborative, if you will, in partnership with the community of practice. And they positively responded. And so there is no contract. There is a set of expectations. We established how a general practitioner can communicate with the pediatric dentist, what the best means of connecting is, how to transfer information as needed. And by and large, they became a relatively important, although informal, backbone for any of the specialty related issues, questions, and cases that might come up, that provided more confidence, I think, for the general practitioner in terms of having a safety net, if you will, of specialty care in their own neighborhood, if you will.
Yeah, thank you. So Domain 2 DTI project, it was pilot tested in several counties, and that basically covers risk assessment, nutritional counseling, motivational interviewing, and silverdimine fluoride.
Right.
So that's the piece that's being expanded. I mean, that's the proposal. It has to be approved by CMS, of course. So it will be available. As part of that, those dentists who participated in this, they had to take a course offered by CDA free of cost. It's called Treating Young Children Every Day.
Right.
So that was a requirement for enrolling in that pilot project. So any continuing education course that's available will be really helpful. So let's discuss about this CE course and how it can be expanded to other counties.
Yes, and the tyke course that you just described was a prerequisite for any of the dentists that we were going to enter into contract with in our community of practice.
Oh, okay.
And so that was a basic requirement, in addition to obviously being a vetted Medi-Cal dental provider, and a willingness to participate in all of the issues, the issue of providing the encounter form back, offering family oral health education with a very specific protocol for how to do that, and basically entering into a contract over and above that which was part of being a Medi-Cal dental provider.
Mm-hmm.
And as you say, those topics that you described were also part and parcel of the continuing education that was provided with UCSF as the partners.
Mm-hmm. So in the DTI project, the reimbursement varies depending on the risk. In other words, those who are categorized as having a high or at high risk for caries, they get 4 visits a year. Mm-hmm. And what we are trying to explore is if some of those visits can be done through teledentistry.
Mm-hmm. Yeah, that makes great sense, especially given the emphasis of primary prevention. Mm-hmm. And of course, that was largely the focus, although we know that many children do present with restorative dental needs. Mm-hmm. But nonetheless, the earlier we see children, the farther we go upstream, the greater the likelihood is that we can, mitigate the epidemic of dental caries.
Mm-hmm. So while you're talking about it, can you expand on the family oral health education incentive payment as well?
Yes, it's a very explicit protocol that incorporates how it really employs the motivational interviewing technique with 6 steps, including, as you say, nutrition counseling, eating practices, goal setting, how one maintains oral hygiene. It's instructional for the parent, the caregiver, the use of fluorides, as I say, goal setting around diet and use of fluoride and weaning, if that's part of it, depending upon the age of the child. It's actually it mirrors a program that was developed in Washington State as part of the ABCD program years and years ago, and was carried forward in Alameda County with a federal grant, Healthy Kids, Healthy Teeth, funded by CMS and HRSA. And this was integrated into the project here in Alameda County as part of the Healthy Teeth, Healthy Communities project. Okay. Very explicit protocol, and the dentists have that as part of their contract to provide that. And they're reimbursed up to twice per year for offering that service outside of the Medi-Cal dental reimbursement. And that money was paid for by through the DTI LDPP project. Historically, Alameda County paid for it and is likely to continue paying for it, even though it may not be covered currently or in the future by Medi-Cal. That may be where the CalAIM part comes in.
It's a very small amount, $20 per visit, and maximum in our program, it was twice a year, so $40.
Yeah.
But I think, that wasn't what motivated them to take on the small children. It was, the CE and many private providers this year and last year said that they wanted to work with the underserved community, but they didn't know how to do it. And HTHC has helped them make a connection with the community.
I see.
Yeah, let me add that doing one-on-one recruitment of the dentists who had indicated some interest and meeting with them, each of them in their practices, led to an educational conversation about the importance of us going upstream and seeing kids as early as possible, as Dr. Khan pointed out, and consequently, 50% of all of the participants were under the age of before the 6th birthday. Now, often we would say to a dentist who said, "I'm interested," but felt uncomfortable about seeing a very young child, that we would suggest that they consider taking a few. And over time, with the continuing education courses, they became more comfortable and consequently either lowered the age or increased the number that they were willing to see. So it's not a mechanistic kind of approach. It was very, very particular to each practitioner and each office. And I think that the negotiation and the outreach and the education that took place all supported confidence and competence in seeing the population that we thought was the most important to reach.
Thank you.
Keiko, is it possible to share my screen? I'd like to share our guide for trainers.
Yes.
A lot of the things that Dr. Fine mentioned about the 6 parts of the family oral health education, including the TIC, those are all included in our guide for trainers. And
Okay.
if the audience is interested, I can quickly show that.
Yes, absolutely. Yes, so please go ahead and share your screen, Dr. Khan.
Thank you. Can everyone see the screen?
Yes.
Yep.
So I briefly alluded to this guide for trainers on one of the slides. And this is actually written and available if anyone wants to use this. And this guide has, so these are the topics that are covered in the CE courses, behavioral guidance, motivational interviewing, science of caries progression. Some of these things, Dr. Fine mentioned. And we also have, at the end of this guide, all those, sorry, I went really fast. Let me go quickly. There it is. So all those topics that have to be included when a practitioner or provider talks about family oral health education, they are all listed here. And so this can be used, and a lot of this information, we took from, what was already available on ADA, website, etc. And so this is what family oral health education component looks like: risk assessment, lifting the lip training, teeth cleaning training, dietary counseling, fluoride supplements, goal setting and follow-up. And then all training have to be followed by these certain things. And the family oral health education visit should be 20 to 30 minutes. And they must document this during the patient's charge. So these are all part of the family oral health education that we are talking about. And it's all there in our trainer's guide.
Perfect.
Great.
There's another question. Okay.
I think there are a lot more comments. So Dr. Penderkar also said, agree with Dr. Fine, the COP's fantastic concept and wonderful pearls of wisdom, Dr. Fine. So great. So we have 5 more minutes. Any other last minute questions that you would like to ask the panelists? Okay, and also I just wanted to read a comment from Jan Resler. She's from Sacramento County, and she says she's also developing and continuing education webinars related to tobacco cessation and the sugar sweetening beverage for dental professionals. So great.
Keiko, there are a couple of questions on the Q&A.
Are there
Was
any?
was there coordination with CHDP?
Yeah, because I only see the comments at the bottom. And then last question was the CDCC stand for, and I think you answered that,
I
Dr.
think it
Khan or
was one
Dr.
of the
Elridge.
first questions. I remember seeing that. So we did care coordinate. And so whenever we received the PM 160 form, we gave that to our CDCCs, and they followed up with those families.
Let me add that the Healthy Teeth, Healthy Communities project actually broadened our provider pool and strengthened the network with the very dentists that we could then refer to. So it really enhanced the CHCP's ability to be able to find dentists who could see children who came out of a with a PM 160 requiring referral.
And I want to add that in Healthy Teeth, Healthy Communities projects steering committee, in the steering committee, CHDP director for our public health department is there. She was a steering committee member. So we had always kept a communication with CHDP. And before HDAC, we had partnership with CHDP for a long time. Dr. Fine started that, and we continuously was, drawing CHDP revenue also and doing the care coordination for them before.
I wanted to mention one other thing. Usually the emphasis is on, providers, and providers were very instrumental in seeing these kids. But we need a combination of care coordinators and providers to make a success like this. One of the things that I heard from multiple dental office staff is that when they gave the family oral health education, they found that the families were more receptive to the information because they had already heard similar things in the oral health education that the CDCCs were giving the families. And so when they heard the same information at the dental offices, it really sank into, the psyche of the families that, yes, we have to brush teeth twice. We have to wean off our kids, the sippy cups. So, they were hearing the same information twice. Once, a similar information, not the same, similar information from both the care coordinators and, the provider office staff. Almost over 80% of the families in our program had never seen a dentist before. So this was very new to them.
I'd like to add something to emphasize the importance of the community dental care coordinators from the perspective of the private providers. In the last month or so, as we discussed wrapping up the program with our partners, almost to an individual, every one of them, when we talked about what was going to happen in the coming year, and they heard that we might be diminishing the number of community dental care coordinators, it was as if they were going to go through withdrawal. They were so committed to that relationship that they were reassured when I said we may have to triage the community dental care coordination function, but we will continue. they really felt that it supported their relationship with the families in such a positive way that it made all the difference in seeing the Medi-Cal beneficiary.
Well, thank you so much. I think we are at time. So I wanted to thank you so much, Drs. Elridge, Dr. Khan, Dr. Ravi, Dr. Fine, Elak, Arash, and the Alameda team for the presentation and having a very engaging session. It was a pleasure to have all of you with us. So this concludes the Lunch and Learn. Thank you all for attending, and we do hope to see everyone at our next Lunch and Learn in February. So have a wonderful day, and thank you again.
Thank you so much.
Thank you. Thank you for having us.
Thank you.
Bye.
Bye-bye.
Thank you.